of cerebral thromborectomy. I hope my screen is visible.
Yes, you are doing good.
Okay.
Voice, screen, everything fine.
Okay, right. So without further ado, let's move on. So I will be covering this trial on the following topics: background, methods. We'll talk a little bit about the results and the discussion, and then we'll proceed to critically appraise the study before we come to the conclusion of this session. So this acute ischemic stroke treatment, and this actually is a picture way back in 1995 when the NINDS TPA trial first came out. This is that NINDS TPA trial team. And at that time, Dr. Gorthi is famously said to have said, until today, stroke was an untreatable disease. In the last 50 years, we have learned a lot about stroke and its management. We have understood that infarction can be prevented by timely reperfusion. We have achieved ability to quickly image the brain and the vasculature. And we have developed drugs and devices to get the artery open. And this has led us, and at the current state, the management of patients with acute ischemic stroke with large vessel occlusion of the anterior circulation within 6 hours is endovascular thrombectomy. When compared to no intervention at all, it improves the chances of getting functional independence, that is MRS score of 0 to 2 at the end of 3 months by about 1.5 times. However, it should be remembered that although these numbers look promising, our ratio of 1.5 looks very good. On paper, the absolute proportion of patients who achieve an MRS of 0 to 1 at the end of 3 months is only 29%, or less than a third achieve this outcome. So the question begs to be asked, why is it? So multiple determinants of endovascular thrombectomy outcomes have been proposed. These include old age, fragility, hyperglycemia, hypoglycemia, fever, and so on and so forth. But probably the most important of these determinants is the extent of revascularization. So this table is adopted from Libeskind et al. You can go to their website for their original publication. So the extent of revascularization is given a score based on the ETC score. And this is between 0 and 3. And the definition of each of these stages is given in this table. As can be seen, about 75% achieve successful reperfusion. So when we are performing an endovascular thrombectomy, successful reperfusion is defined as a TC score of 2B or greater, right? So around 75% do achieve this landmark or this outcome, but only 34.4% have no or minimal disability at the end of 3 months. So where is the problem? So we have reperfused, we have revascularized. So why is it that we are not seeing the corresponding outcomes? So this leads us to an interesting concept called no reflow. This was first described in the early 2000s. So I'm not sure if this picture is very visible, but basically there is a right MCA stem occlusion at the time of admission. And as you can see, there is no obvious infarct in this CT. And this is a perfusion scan that is showing a large MCA perfusion deficit. Now this patient has been treated, his artery has been opened up, and you can see there is some distal flow in the right MCA. However, the perfusion deficit remains, and this is translated into an infarction. So one of the interesting reasons that was postulated why this happens, this is the no reflow. And the reason why this happens, they have said, is because the microvasculature and the capillaries that surround each of the neurons remains closed despite opening up the large vessels. And this phenomenon of no reflow was initially dismissed as an epiphenomenon because they felt that once the neuron is irreversibly damaged or infarcted, it will anyway cause swelling and the corresponding capillaries will be blocked either because of the endothelial swelling or because of by trapping fibrin and RBCs inside it. This is again revisited very interestingly more recently in 2019 by Kostier et al. What they performed was they used source images of digital subtraction angiography as the patient is undergoing an endovascular thrombectomy. And they used these source images using bolus tracking techniques to reconstruct perfusion images. So this is the initial DSA. As you can see, there is an occlusion at the level of the ICA. And this perfusion image shows a large perfusion deficit that is present in this patient. Now, endovascular thrombectomy has been done, and there has been successful reperfusion. As you can see, this is almost more than 2B grade, but an area of hyperperfusion remains. So this again has translated into an area of infarction. So what is the reason for this? So from all of this, we can understand that reperfusion is probably a better indicator of outcomes as against revascularization. This improved microvascular patency, impaired microvascular patency after ischemia may be an epiphenomenon. On the other hand, it can also be a key to improved outcomes. It is believed that early use of thrombolytic agents after recanalization improves patency. I will now take a short break here, and I will share with you a small video. This is please bear with me. I seem to have lost that, so let's go back. Basically, that
You open that window.
You can carry on.
Yeah, I will carry on. So if you're interested, you can go and watch this video. It's a 1-hour interview of Dr. Renu, who's Dr. Chamorro, who is one of the authors of this paper. And he describes in it the premise that whatever we had discussed so far about microvascular obstruction being one of the reasons why there is poor outcomes following endovascular thrombectomy. And he also discusses the interesting findings of this study and how it relates, and he places it in the current context of things. So if you're interested, please go ahead and watch this interview. So I will move on. So this choice study was done with the research question, is RTPA safe and efficient as an add-on to mechanical thrombectomy in patients with acute ischemic stroke and complete or near complete recanalization of a proximal vessel occlusion and successful vein reperfusion on cerebral angiogram corresponding to an MTC score of 2B or greater. So with this research question, they went on to design a randomized double-blind placebo trial, which is a phase 2B trial. The setting was in Catalonia, Spain, over 7 stroke centers, which have previously participated in endovascular thrombectomy trials, the REVAS-CAT. So randomization was done using a computerized proc plan in SAS. It was centrally administered. It was stratified by center and use of intravenous thrombolysis prior to randomization. They used block sizes of 4 and allocation concealment. Drugs were obtained from Boehringer, which supplied both the alteplase as well as the placebo. And the codes after allocation were directly released to the manufacturer. And from there, the drug was delivered to the neurointerventionalist. So essentially, this provided the method by which, and the 2 drugs, both the placebo as well as alteplase, were similar transparent lipid solutions and were provided in similar fashion. The patient's neurointerventionalist and the central lab for imaging evaluation were all blinded to the intervention. So they included patients over the age of 18 years who were eligible for endovascular thrombectomy using standard criteria as documented in the guidelines. They had to have a pre-morbid MRS score of 0 or 1. And post endovascular thrombectomy, they had to have an established flow of 2B50 or greater. This 2B50 is nothing but in the modified TC score, 2B stands for greater than 50% perfusion of the vascular bed. And this has been further split into 50 to 67%, that is half to 2/3, and more than 2/3 to less than 90%, that is 2B50 and 2B67. 2C is more 90 to 99% perfusion, and 3 is almost 100% perfusion. So the study medications, as we discussed, were provided by Boehringer et al. And they once the codes have been generated, they were directly delivered to the manufacturer who made the solutions. It was a weight-based regime for alteplase given at 0.225 milligram per kilogram. And it was both these drugs were given as an intra-arterial infusion over 15 minutes. This was given distal to the lenticular striate and proximal to any residual thrombus. In case there is a residual thrombus, the neurointerventionalist was also allowed to give to selectively cannulate the vessel and provide the intervention. But the neurointerventionalist as well as the patients were blinded to this intervention. Their primary outcome of interest was the modified Rankin score of 0 to 1 at 3 months. Secondary outcomes, they were interested in imaging outcomes, namely the proportion of patients with improved angiographic findings, MTC scores, the final volume of infarct, the infarct expansion, and the infarct expansion ratio. They were interested also in clinical outcomes, predominantly in the form of MRS shift analysis. They were also interested in the proportion of patients with MRS of 0 to 2. They were tertiary outcomes, they defined as proportion with Barthel index 95 to 100 at 90 days, or ischemic worsening with more than 4-point increase in NIHSS that 2 to 3 days after onset of stroke, and quality of life at 90 days. Sample size they calculated for the primary outcome, that is the proportion of individuals who achieved an MRS of 0 to 1. They assumed a controlled event rate of around 40%, which is reasonable. And they expected a difference of about 21%. That is, they expected that about 61% of those receiving intra-arterial alteplase will have this MRS of 0 to 1 at 90 days. For a power of 80% and alpha of 0.05, they calculated numbers as being about 100 in each arm. The primary outcome, they performed analysis using an adjusted disk difference using binomial regression adjusted for stratifying variable of intravenous thrombolysis. Other outcomes, they estimated as odds ratio adjusted for the stratifying variables. They performed sensitivity and subgroup analysis. They have actually published, they have actually provided a detailed statistical analysis plan as a supplement to the original article. Those who are interested can please look at this. The trial, however, was terminated early. The reasons cited for this were this trial extended between 2018 to 2021 and was conducted during the COVID pandemic. And as a result, there was a very slow recruitment of participants. And also they cited the difficulty in procuring placebo as reasons for early termination of the study. Coming to the results, this is a consort diagram. About 1,825 patients were treated with endovascular thrombectomy in the 7 centers in Spain during this period. But as you can see, 1,704 were excluded, which is almost 93% of those screened for eligibility. The most important reason for exclusion were, of course, MTC scores of 3. This was subsequently in November 2019, they enacted a protocol amendment to include these patients also in the eligibility criteria. And subsequent after November 2019, these patients were also included for randomization and were included in the study. The other important reasons were MTC scores not meeting the criteria, or there is an active contraindications for alteplase, which accounted for about 200 and 300 participants each. Overall, around 121 participants were randomized, 65 into the intra-arterial alteplase, and 56 into the intra-arterial placebo. Around 61 patients did not receive intra-arterial alteplase, of which 2 received less than 50% of the recommended dosage, and 50 of the 52 patients in the intra-arterial placebo group received the Arginine placebo infusion. With only 2% again received less than 50% of the recommended dose. Overall, 61 participants were included in the primary analysis in the intra-arterial alteplase arm and 52 in the placebo arm. The baseline characteristics and demographic features were about same for both groups. Patients were aged about 73 years, and most of them were belonging to the white race. The male-female ratio was about 1. And they had hypertension was seen in about 40% and diabetes in about 1/5, which is similar to the stroke population used in other endovascular thrombectomy trials. The NIHSS was about 14. One of the exclusion criteria being NIHSS more than 25. So these were moderate to severe strokes that were included in this group. Blood pressures were and blood sugars were also comparable between the two groups.
Only on the workflow, do you feel there is some 30, 45 minutes later?
Sir, I will come to that.
We'll discuss later. Okay.
This is again a continuation of the same table. And again, sir was saying there were two important things that I want you to look at. One is the treatment with intravenous alteplase before randomization. Now, the way the study was structured, that the neurointerventionalists were given the option to stop the intravenous alteplase that was already running in these patients once they are randomized. So only about 60% of these patients in both arms received their full dose of intravenous alteplase. And again, this full dose means not necessarily full dose. What they defined as full dose was more than 50% of the drug medication has been received. And as far as workflow times go, again, as Sir had said, there was the patients who were randomized to intra-arterial alteplase. The time to randomization as well as the time to intervention was about 40 minutes on an average. That is, on the median time to all of these was about 40 minutes earlier for the alteplase group as compared to the placebo groups. Most other parameters were more or less comparable. So coming to the primary outcome, which is the MRS of 0 to 1, was seen in 36 or about 59% of those patients who were randomized to alteplase, and about 21, that is 40% of those who were randomized to placebo group. This resulted in an absolute risk difference of around 19%. However, following adjustment for intravenous thrombolysis, as was pre-specified and using a binomial regression model, they estimated the absolute risk difference comes to about 18.4%, with a confidence interval ranging from 0.3 to 36.4%, and a p-value just meeting significance of 0.047. Of the secondary outcome, they found that the angiographic scores did not differ much. However, the infarct expansion and the final infarct volume, as well as the infarct expansion ratio, were all in favor of the alteplase group, though none reached statistical significance. The MRS shift analysis is shown in this figure. Again, as can be seen, although numerically more people did end up improving their MRS scores by about 1, this was not, again, a significant difference. Tertiary outcomes where improved Barthel index was seen, that is corresponding to the improvements noted in the modified Rankin score. However, there was no difference noticed in the quality of life, and there was no difference noticed in the ischemic worsening. Safety outcomes, they reported only as proportions, and there were no significant safety concerns. There were 3 fewer deaths in alteplase group and 3 more bleeds, both hemorrhagic infarction as well as parenchymal hematomas in patients who were given alteplase. This is a sensitivity analysis that they have performed. Again, this is a very busy slide. I don't expect you to look at all of it, but please look at this model number 6, which has been adjusted for the time to randomization, which we had already seen was about 40 minutes earlier in the alteplase arm. And once we adjust for that, p-value becomes non-significant, and our confidence intervals range from -0.3 to 35.5%, meaning that there was no statistically significant improvement in these. There was no statistically significant difference between the two groups. These are pre-specified subgroup analysis. Again, it is interesting to note that patients who received previously full dose of systemic, who did not receive full dose of systemic alteplase, that is 50% or less amount, had a better outcome with intra-arterial alteplase. And similarly, it is interesting again to note that patients who apparently did very well with revascularization, that is already achieved a TC3, already achieved perfusion of 90% or more on their TC scores, actually did better with intra-arterial alteplase than those who did who achieved only about 50 to 67% perfusion. So they felt, the authors discussed that there's improved microcirculatory reperfusion.
Hello, Dr. Rajeshwari, 1 second. Can you go back to the primary outcome?
Yes, sir.
Can you go back to primary outcome
Yes,
and comment on the confidence interval?
So it's a very narrow confidence interval. I will comment about it in more detail.
0.3 to 36.4. How can it be
Yes, sir.
narrow?
It's a very large, wide interval with very low precision. I will be discussing that subsequently.
Okay.
So here we were. So the authors discussed that this is an improved microcirculatory perfusion, which is translated into improved functional outcomes. And this is because the IV alteplase has got better access to smaller clots once we open up the large vessel occlusion. Overall, it appears to be a safe intervention. There was no significant safety concerns. The limitations that are cited by the authors include the following: that is early termination of the study, and this may result in an overestimation of the effect sizes. Lower number, meaning poor precision. Smaller fraction of eligible population means the outcomes are less generalizable. They performed a dichotomous rather than a shift analysis, and this they justified saying that this was because the outcomes that they were interested in, namely MRS of 0 to 1, was probably better analyzed using a dichotomous analysis rather than a shift analysis. In conclusion, they said that large vessel patients with acute ischemic strokes with large vessel occlusion with successful reperfusion following EVT, use of adjunct intraarterial alteplase compared to placebo resulted in a greater likelihood of excellent neurological outcome at 90 days. So we will now proceed to critically appraise the results of this study. We will first come to the PICOT. So the patients group that we were interested is in acute ischemic stroke patients who underwent endovascular thrombectomy and achieved ETC scores of 2B50 or greater, that is more than 50% reperfusion of the distal arterial bed. Our intervention was intra-arterial CPA, which is a dose-based regime, which was given as an infusion over 15 minutes. That was given distal to the lenticular striate artery, sometimes with selective recanalization, but usually proximal to the site of occlusion. The comparator was an intra-arterial infusion of arginine with polysorbate, given in a similar manner. The outcome was MRS of 0 or 1, that is no or minimal disability, and the time course that we are interested is at around 3 months. So coming to the critical appraisal, multiple protocol changes were done during the development of this, during the process of this study. So the last protocol change was performed in November 2019. So until November 2019, patients with ET3 were not were not eligible for the study population. As we had seen in the subgroup analysis, this particular group actually seems to be very much benefited by intra-arterial alteplase. Second thing, that major protocol change that they performed was again in November 2019, when they changed actually their primary outcome. The primary outcome, they reported the protocol of the trial, and this is available in the International Journal of Stroke 2019. And at that time, they used an ETC score, improvement in the ETC score at around 10 minutes after the end of the study treatment as their primary outcome. However, they used similar numbers. That is, the proportion who do not with placebo was 40%, and the proportion which improved on giving alteplase was 20% more, and similar numbers were calculated. And so I do not know whether this will be because of a reporting bias, but it is something to be considered when we consider the outcomes of or the results of this, namely that the primary outcome has been while the study was in progress, and the numbers have not been changed, and the sample size calculation has remained the same. Early termination of the trial has been done, and this has been considered by the authors as possibly resulting in overestimation of the outcome. All of these things, that is protocol changes which probably benefit the outcome, possibly an outcome change again to improve the effect sizes, all of these will probably inflate the effect size that we are looking at. Second thing, again, we had discussed previously, was time to randomization and time to start of treatment. We had already seen that there was about 40 minutes earlier, the median time to randomization. This is I think very familiar to most stroke neurologists. This is the Khatri curve, where we can see the probability of good clinical outcome. Here it was MRS 0 to 2 as plotted against the time to reperfusion. So from the stroke onset, as you can see, a 40-minute time difference results in a significant change in the proportion of participants who can get good clinical outcomes. And this again may probably artificially inflate the effect sizes. One of the sensitivity analysis that they performed and which highlighted previously is also consistent with this. Their effect size, their calculated effect size remained around 17.4%. However, their confidence interval became ranged from -0.3 to 38%, including 0 once adjusted for this time to reperfusion. Then there was a premature termination of intravenous thrombolysis. Now, when we they have, as we had previously discussed, if the patient had received more than 50% of the IV TPA, they were said to have received complete thrombolysis, and this occurred in about 60% in both groups. It is to be remembered that once we adjust for this use of IVT, already there was a reduction in the there was a reduction in the calculated absolute risk difference, and it came down to 14.5% from 18.4%, and the confidence interval became it started including 0, and it was non-significant. When we calculate odds ratio for the functional independence for this choice trial using the numbers that are given in the study, the odds ratio for an MRS of 0 to 1 from the numbers is about 2.12 with a 90% confidence interval ranging from 1 to 4.5. When we look at this confidence interval, this is very similar to the confidence interval that can be obtained by plain bridging therapy. That is intravenous thrombolysis that is preceding endovascular thrombectomy as compared to endovascular thrombectomy alone. So this is obtained from a meta-analysis. The odds ratio for a 0 to 1 MRS is 1.328 with a confidence interval of 1.118 to 1.5. And this is overlapping with what we calculated from the choice trial. So whether or not it is merely the completion of the intravenous thrombolysis, that is completion of the IPA dose that is required for the success for completion of the thrombolysis, whether that is what made the difference is not known. This again may artificially inflate the effect size because this intraarterial TPA was only given in the intervention arm and was not given in the control arm. Randomization, allocation, concealment have been fairly described. Blinding of outcome assessors have not been described. The patients and
what is the last point about? Was it about bridging thrombolysis?
Yes, sir. Basically, the patients in the intraarterial, in the intervention arm in this study choice trial received the extra dose of the remaining dose of the IPA probably. And the effect sizes, the odds ratio is very similar to that which we obtain using the bridging therapy. So possibly the patients who received intraarterial alteplase probably only completed their IVT dose, whereas those who were randomized to the placebo group did not receive this alteplase. They received a lower dose of alteplase, and thereby they did not get good benefit.
Could you see this? There is also the treatment with the intravenous alteplase before randomization. Numbers are given in both the groups.
Actually, what they have done, sir, is that they have given they have given the neurointerventionalist the ability to stop IV thrombolysis once the patient has been randomized. Only about 60% of patients in both groups, both the alteplase group as well as the placebo group, received more than 50% of their alteplase group. So again, the key word being more than 50% of the IV thrombolysis. Now, those people who were randomized to the intraarterial alteplase, they received the remaining, that is 0.225 milligram per kilogram, on an average around 15 to 22 milligrams of intraarterial alteplase, they received as an infusion. Whereas those who were randomized to the placebo group, they actually did not receive this extra dose. So ultimately, the patients the total dose of that was obtained, was given to these participants in the alteplase group was probably just the right amount to complete the intravenous thrombolysis. So there was a non-differential bias in favor of alteplase, and this may artificially increase the effect size. And this is again evident from the fact that their odds ratio, if you calculate like that, is very similar to that obtained for bridging therapy.
Right. But they are trying to show only the frequencies here as around 62 and 60%.
Yes,
but
sir.
there was a difference in the actual dose received as well, isn't it?
Yes, sir. So randomization and allocation concealment have been well described. There is a blinding of the patient, the neurointerventionist, as well as the central imaging laboratory. However, there is no mention of blinding of outcome assessors. However, MRS is fairly well accepted modality and can be, and they have probably used trained assessors. The other thing is they have used arginine as a comparator. Now, arginine is a substrate of nitrous oxide synthetase, and it is by itself has got vasodilatory properties. And so this may actually reduce the effect sizes against the alteplase. Multiple statistical analyses have been performed. However, these have been well described and have been provided as a supplement to as a statistical analysis plan. No corrections were used for the p-values during all of these methods. However, they have said that since they anyway terminated the trial early and they have used only one primary outcome for which they were adequately powered, they have not, and all other outcomes they have given us only exploratory analysis. Finally, what Dr. Gorthi was saying, there were very small numbers resulting in poor precision. So you have a confidence interval ranging from 0.3 to 36.4% for the improvement. And again, they have these are very inadequate numbers. There were almost 3 fewer deaths and 3 more bleeds with intraarterial alteplase. These are not comparable to what we see in EVT or intraarterial thrombolysis data so far, and not enough to conclude that intraarterial RTPA is safe intervention. That being said, there is a lot of actually information already available on the use of intraarterial TPA, and hence probably we can conclude that intraarterial TPA probably does not have very many safety concerns surrounding it. Role of sponsor has no role for Boehringer has been declared in their declarations of interest. However, both the drugs were both the alteplase as well as the placebo were actually provided by Boehringer. And one of the reasons cited for early termination of the trial was that there was difficulty in procuring placebo due to expiry of placebo, quote unquote. So what exactly this means for the trial results, again, remains a conjecture.
Boehringer's role, they only clarified that they never intervened in the.
Yes, sir. They have said that there is no role for analysis or anything, but they also cite one of the reasons as being there is expiry of the placebo, which was provided by the Boehringer. Now, whether Boehringer used this as a method to early terminate and publish the results early, I do not know, and it's open to conjecture.
And the other sponsors are Stryker and Medtronic.
Yes, sir.
But probably.
And they have also received funding from the Spanish government and one NGO also.
Yes. The study is mainly in Spain, isn't it?
Yes, sir.
But if you look at the Hispanics are a much smaller percentage compared to the.
So they define Hispanics as being with South American descendancy.
Oh, okay.
And they included everyone else as being white European.
Right. So, okay, you're going to, yeah. Can we listen to some queries and questions from the audience?
There are some more slides, I think, sir.
Yes.
Dr. Rajesh, you have any more slides?
Yes, sir, a couple more.
Okay, you completed. Sorry. Please go ahead.
So this study has got low external validity, and this is something that has been considered by the authors themselves. This is actually a tree map showing the number of stroke patients who are managed actually in Catalonia, where this study was conducted. And this is obtained from the Hermes stroke registry and the Revascat trial published in Stroke 2015. And there, as you can see, most of the patients patients actually, even in their setting, receive no revascularization. Only a small proportion of about 1/10 receive endovascular thrombectomy. And of these also, only about 8% have been included in this study. So you can imagine how selective they have been in picking the patients who have been included in this study. And so the external validity of this study remains under question. So in conclusion, after our appraisal, we can say that from the results that they have published, the number needed to treat will be about 5 patients to receive adjunct intra-arterial alteplase for 1 to achieve functional independence, defined as MRS of 0 to 1 at the end of 3 months. However, this is likely to be an inflated estimate, as we have already seen. Timing is probably a very important factor that is confounding this, these outcomes or these results. And again, the benefit may be driven by the use of TPA, similar to that of TPA used in bridging therapy. So further studies will probably be required to really understand the role of adjunct intra-arterial alteplase for improvement of outcomes in endovascular thrombectomy. That's all from me. I'm open to questions.
This outcome, death at 90 days, is 8% in the alteplase group and around double that in the placebo group.
So they have included 5 and 6 as in this MRS shift analysis, but in the safety outcomes, they have said that there are about 3 fewer deaths in alteplase group as compared to the placebo group. But both these numbers are within the range for endovascular thrombectomy trials. So patients who with NIHSs of 14 to 25 with large vessel occlusion who do undergo this thing, this is appropriate numbers. So it's not too big or too small.
Now, death at 90 days, almost double in the placebo group. They are showing that it is only half of it in the alteplase group.
Yes.
90-day death. Yeah.
Yeah. But these numbers are too small to draw any conclusion. And the numbers of deaths that they have given is like the proportion. If you calculate the confidence intervals and all, it will be approximately what we would expect from this cohort of patients. No less than greater.
Right. I have just one question. Theoretically, after a revascularization by mechanical thrombectomy, if you infuse a thrombolytic drug, because of the hyperperfusion or reperfusion injury, are the chances of bleeding or hemorrhagic transformation higher if you give post-thrombectomy thrombolysis?
Actually, sir, that's a very interesting question. I would like to show you this. I think if you get time, we should read this paper. Basically, this et al., what they have done is they have looked at the source images on DSA following thrombectomy, and they have made perfusion maps, and they have correlated it with subsequent hemorrhagic, either hemorrhagic transformation or parenchymal hemorrhage. And what they have seen is whenever there is a hyperperfusion or a hypoperfusion, both are associated with increased risk of hemorrhagic transformation. So what these people say is that if you give an early thrombolytic agent, so the key here being early thrombolytic agent, after opening up the vessel, there is time enough for the small distal emboli to be lysed and open up these microvasculature and reduce the areas that are hypoperfusion, thereby improve outcomes. So it is not, and this concept of it being relatively safe, I think, is fairly borne out by what they have seen in the outcomes of the trial. There are no real big safety concerns that has been studied.
Questions from audience, please.
Dr. Anand, Vaibhav, anything?
Yeah, good evening, Dr. Anand. Dr. Anand,
I'm here. Can you hear me?
Yes,
So I had
yes.
one question, I think you commented about bridging and so what was the dose of, alteplase that was given in the two groups, because you later on you commented that, technically the patient, which got, intra-arterial alteplase later on would have been equal to the normal alteplase, the 0.9 milligram per kg.
Yes,
So,
so actually, like I had discussed that the neurointerventionalist was given the option of stopping IV thrombolysis. So around 60% of them received more than 50% dosage. So let's assume that a patient needs 90 milligrams of IV TPA, and he has received 45 milligrams of IV TPA, right? So then this patient is randomized into alteplase group as well as into the arginine group. So if he is in the alteplase group, he receives an extra 22.5, which is about 67 to 70 milligrams of TPA. Whereas the person in the arginine group has received only 45 milligrams. So this is a far lower dose of TPA than recommendation. Whereas this is approximately what would have been recommended. So around 70 milligrams, more than 2/3 of what is recommended has been received by this patient. So we are giving a dose that is almost similar to what we use in bridging therapy. And this is similar, and the outcomes are also similar to what will be seen for bridging therapy.
So then could you not make an, exactly opposite, that maybe this was not needed and we should just proceed with the normal 0.9 milligram per kg alteplase? Do you see what I'm saying?
Yes, sir. That is what I had mentioned over here, that it may be driven by the benefit of this TPA itself. It's not about when you give the TPA or how you give the TPA, it's just about giving the TPA. So if we give the TPA early enough and a full dose, maybe that is more than enough to achieve this outcome. So maybe in subsequent studies, what we would need to do is we need to compare this adjunct intra-arterial alteplase as against a bridging therapy rather than study as designed here.
And I think the second issue which comes, I think even in future studies are going to be very difficult doing that, because now with the two extend IATN case, which both, again, the difference is 22 versus 10%, we may just be giving 10 hectares. But again, I think this is just, I think to do another study along the same lines will be difficult. I don't know what Dr. Narayan or Dr. Gorthi feels about it.
I got a different take, Dr. Rajesh. I just want to discuss with all my colleagues one point. Dr. Rajesh, did you review the recanalization of PROACT 2 trial? How much is the recanalization?
Yes,
it is almost
the PROACT 2 was a
the recanalization rate is 68%.
66%, yeah.
Yes, sir.
And this mechanical thrombectomy is 75%. Right? That's what maximum. Yes. So I don't know why we are not doing only intra-arterial therapy is my question. Sir, why are we wasting so much money on mechanical thrombectomy when the difference is so low? Anand, share your, Dr. Partha, whoever, Narayan. I have this doubt. Because the PROACT trial is a trial which has proven intra-arterial therapy is beneficial. It reopened about 66 to 68% vessels. And so it's a randomized control trial. And mechanical thrombectomy is also opening up to 75%. And which is more cheaper. I think Indian setting, we should do primary intra-arterial thrombolysis.
I think one part.
Go ahead. Comment on that. Actually, I had a similar question, so I just reviewed a little bit of literature on that. So this is how intravenous thrombolysis, primary arterial thrombolysis, and adjunct arterial thrombolysis to endovascular therapy, how they compare. So when we give intravenous thrombolysis, the odds for death or dependency are reduced by about 0.8. And this is again from the Cochrane review. Whereas when we use primary intra-arterial thrombolysis, the numbers are more or less similar. However, the confidence interval is much wider. And this is probably because of the fewer numbers that are present. For adjunct as intra-arterial thrombolysis to endovascular therapy as an adjunct, when we use the similar odds, the odds ratio is about 1, which is about the same in both groups. And the problem over here is that there's very little evidence to support or to refute this. And this is a more recent meta-analysis that included actually both randomized as well as quasi-randomized trials. And this is the outcome. So yes, primary interarterial thrombolysis is not a bad choice, but we get almost similar outcomes with just intravenous thrombolysis. Now, whether adjunct arterial TPA to EVT will improve the outcomes is the question.
Interarterial primary may extend the time window. And if you have the recent advances in the imaging, we may have better definition of penumbra, and we can extend the time of interarterial therapy.
So another
primary.
They are saying is
what do you agree about that? You can extend the time window of primary interarterial thrombolysis, and if you have diffusion perfusion mismatch and things like that, you may extend further, because if you adhere to tissue clock than the time clock.
I think one, Dr. Gorthi, again, I don't know, but with the PROACT 2, they just included M1 and M2, and I don't know the difference between M1 and M2. I mean, I would have to look it up. But the carotid T lesions, the worst, patients, were not included specifically. So maybe the outcomes were better in PROACT 2 because they did not include the toughest of the clot, which is a carotid T junction. So that may be one reason. I think that's what I'm thinking. That may be the reason. But and as you know, in endovascular thrombectomy, I think one big difference between the two groups is the your Gorth lesion, your carotid T lesions, which were not included in the PROACT 2 trial. Right. So that may be the reason.
No, but resource poor countries, if we have angio available and we don't have to spend 3 to 5 lakhs to 6 lakhs of mechanical thrombectomy, you can give a treatment almost as effective or slightly less with primary intraarterial. That's what my my
actually, I am not an expert, but my understanding is that there will be some technical problems also in providing intraarterial thrombolysis, because unless we are when we perfuse, it will flow back. So unless we can selectively recanalize to distal, to cross the thing and give the thrombolysis, may not be very effective.
No, it is effective because we have done it in Manipal, and we tried presenting this, but it was not allowed. We did with good success, because Manipal we didn't have mechanical thrombectomy a couple of years back. Then we used to do interarterial.
Okay, sir.
Yeah, before I joined JIPMER at SWIMS Tirupati also, I have the experience of doing it on 2 cases, but both were basilar. And one of them, there was excellent improvement. The other one actually we lost also. But even the one who actually improved, like quadriplegic patient becoming conscious and moving all limbs and all, we had another clot in that patient, another stroke in that patient after 4 or 5 days. And so that was the thing. But they were not in the MCA territories.
Yeah, that's true. It requires to be studied, I think. But the market forces won't allow the study to come up.
Yeah, but I think you do have a point that we certainly intraarterial thrombolysis is certainly not a dead chapter. There is some scope for improvement, especially in those patients who have got other contraindications for thrombolysis, and in those whom these stem occlusions and very large
like thrombus in left ventricle, left atrium, all these things can cause problems. Intravenous and interarterial comes handy.
I mean, I don't know why they could have waited for some more time and allowed the full study to be completed. What is the hurry to stop it? The arginine not being available, a lot of temporary problems only.
I think Dr. Partha, you're quiet.
Yeah, where is Dr. Partha?
No. I'm actually new to all this critical appraisal. I'm enjoying it. But yes, I took the point of,
Yes.
the intra-arterial thrombolytic agents not being able to get to the microcirculation beyond the lenticular striate branches unless we manage to negotiate the clot first. And that I think may be the issue about how intra-arterial thrombolysis, without passing through the clot structure first, we'll be able to get to the smaller vascular bed. That's what I've seen on the angiographic intervention.
Actually, this data from this study. Yes. Please continue. Yeah. So this data from this study looks that I mean, the safety concerns. It sort of obviates the safety concerns, but I am really worried about.
Sunil, this is phase 2B. It is not to be generalized. It's not a efficacy or effect study.
Yeah, but the question is, as Dr. Vaishnava also told, whether there is going to be one more study. That's I mean, it's I mean, I doubt whether people would venture into doing one more study.
It's
How do you?
It's like Nova 7 phase 2, and afterwards everybody got excited. Then after phase 3, they have left it. So it's phase 2B. So I think generalizability question doesn't arise at all. It's only we just see the hypothesis generation again, whether it is possible or not. Dr. Ilavarsi, you are quite. What is your comment?
Rila, where are you?
Sir, hello.
Yes.
What are your comments?
Yes, sir. I was listening. Actually, I also feel that the 40 minutes delay between the two arms could have actually turned the tables, and that is a huge difference even after randomization that has occurred. Yeah.
But what are your thoughts about this primary intra-arterial therapy?
Sir, in the beginning, urokinase was used for quite some time, and our interventionists also used to fondly remember those days when mechanical thrombectomy devices were not available, and still they used to give the intervention. But personally, I feel intra-arterial and intravenous, there wouldn't be much difference because giving it intra-arterially, even if you give it in the carotid, in one circulation time, it is going to enter into the venous circulation again. And so there should, actually theoretically, there should be no difference between intravenous and intra-arterial therapy. And I think that is what is reflected in this study also.
You mean to say that at the site of the clot, a higher concentration wouldn't make much of a...
that is just for it may stay there for just some 8 to 10 seconds at the maximum.
I have been associated with about 20 procedures. We give aliquots of 3 milligrams up to 20 milligrams, and we see the thrombus being lysed and reperfusion takes place. Okay. Time window is extended than the intravenous if you have intra-arterial. So these are two observations which may be,
Sir, that is what happened. It's happened in the Extend IA-TNK also. In Extend IA-TNK, they gave the intravenous thrombolysis first, either TPA or either alteplase or tenecteplase. And after that, they did the DSA. In that study, as far as I remember, tenecteplase had 22% recanalization after intravenous administration, and alteplase group had 10%, so that they did not even have to do the endovascular therapy. Just after IV TPA, either alteplase or tenecteplase, 1 in 10 patients or 1 in 5 patients had complete recanalization. So it would be difficult to say that intra-arterial works better than intravenous unless there is a head-to-head comparison.
It's not settled. The issue is not settled because 66% recanalization of M1, M2 is a very high reading. So that's what is, we keep thinking about it. Anyway, good. Any other comments before we wind up?
If I may just play a little bit. Yeah. So actually, this I had commented when we were discussing, this is a subgroup analysis of the trial. Here actually, 2C and 3, which is more than 90% distal perfusion, Actually, those patients are the ones who benefited most from intra-arterial alteplase as compared to those who had a poorer perfusion. So this goes to reinforce the original premise of this study, that it is the microvasculature which is opening up secondary to the intra-arterial alteplase rather than the large vessel which we are opening up. I don't know.
Okay. Thanks.
One comment from me also, to the final comment from me. For me, maybe a little more importantly, this has demonstrated the feasibility and safety of post thrombectomy local infusion of drugs, and it might pave way for use of other neuroprotective drugs, local administration. So for the feasibility of which has been probably shown by this. Of course, there is no neuroprotective drug used here, but then that might be one way of taking this forward. We don't have any proven neuroprotective drugs as yet. Many of them were shown some partial improvement, only to be refuted in the large. Shown in small trials. All this edaravone and Ozagrel and all these various drugs. But then later on, they didn't stand the test of time. Maybe I don't know whether these or some other drugs locally post thrombectomy we could try. This study has shown the feasibility for that.
The other thing is they had restricted the inclusion criteria as TC2B or better. So had they included other patients, like for example, patients who did not have adequate recanalization after endovascular therapy, they would be the patients in whom the maximum benefit could have been demonstrated. Patient who has already 60%, 70% vessel opened up, I don't know how much additional benefit they would be getting as compared to someone who had a TC0 or 1.
So that is the premise of the study. Actually, they say that around 70% have achieved this kind of flow. 1/3 of them have MRS 0 to 1 at 90 days. And their premise was that this was because the microvasculature is what is the key. And that, I think, is what they wanted to see by giving intra-arterial alteplase and opening up these microvessels by removing all the distally migrated. And I think like this 2C3, that is more than 90% perfusion, is the one that is maximally benefited, and this is the one that is driving actually final results that they show. Whereas here there is 19 out of 20% patients are of 2C3 have good outcomes, that is 0 to 1, whereas of the 21 in the placebo group have. And whereas in the 50 to 89%, it's almost comparable, like 17 out of 34 and 13 out of 31. So
but these subgroups might be underpowered, and whatever we are.
I agree, that is true. But this is the premise. This is the interesting discovery. So.
Right. Any other comments? I think probably we have, but the fact that we are exploring what we can do post thrombectomy and after opening up the vessels, as far as the stroke treatment future plans are concerned, I think this is an important area. We just don't stop with opening up the arteries. We could probably, even if this helps in opening up the improving the microvasculature, that could actually give better penetration to the tissue area for other neuroprotective drugs, etc. So this is one comment I would like to make. And Dr. Gorthi, you could probably wind up.
Yeah, I think we had a very interesting discussion. And yeah, please.
Yeah, what's happening out here is probably the microcirculation which gets clogged up. What was the stent retrievers being used? Was there complete extraction of the clot with the devices used? Is the question. And even if the complete clot is completely extracted, there will always be the possibility of small debris going off into the microcirculation and causing distal, infarctions, which is where possibly this intraarterial thrombolysis has got value in dissolving the remnants of the thrombi that will distally propagate. So is there an effect from that point of view?
So they have primarily included patients who have achieved revascularization, means that distal perfusion is more than 50% at least. And in fact, about 1/3 of them having 100% reperfusion, more than 90% reperfusion of the distal bed. And what you said correctly is what they are also hoping for, that there will be distal emboli. Per se, there is other reasons for which there will be fibrin clots that are forming inside the microvasculature. And they are hoping that by giving an intra-arterial alteplase an adjunct after a successful thrombectomy, they will open up these microvasculature also and thereby improve perfusion and thereby improve.
Yes, I mean, when we are actually doing the mechanical thrombectomy, there are lots of showers of broken debris that go distally. From that perspective, it's often useful to put an intraarterial thrombolysis anyway as an adjunct to the mechanical thrombectomy. Leave aside the secondary utility of using this clot lysis mechanism.
They say after the brain protection devices, these debris probably reduced. Yeah.
Yes, and that's actually practical, and we see it all the time of these small clots flying off as soon as the thrombectomy is incomplete extraction. It's not very, many of these clots have red thrombi, white thrombi of different friability, so it's very difficult to take all of it out. Some of it remains, and just to dissolve those bits, I think the intraarterial thrombolysis comes in as a useful secondary adjunct.
Dr. Gorthi,
the same mechanical.
Yes, sir.
Can you, if you have this your series, or if you want to share your experience with the intraarterial thrombolysis, any one of the convenient future sessions, that will be very welcome. And I mean, it will be nice for us to just discuss these kind of.
Yeah, the same point. If it, mechanical thrombectomy is so much operator.
Do you have a series, some?
Yeah, we sent a couple of years back from Manipal 4 cases of intraarterial therapy to Indian Stroke Association. They didn't accept this thing. I have to dig it out now where it is. So they didn't accept. But what this thing is, we can't say everybody is so efficient that they'll remove the whole clot. But we know that if a drug is given which lyses, it's much more reliable. And distally, it also lyses the clots in the microcirculation.
I think
we have done exceedingly well today, and maybe I think we should now leave. It's already 1.5 hours.
Yes. So I think probably
for everybody's benefit, I have made it live on YouTube on Neuro Pathshala. So anybody wants to visit Neuro Pathshala can visit and review the proceedings.
That will be quite good, because being a work day, many people may not have been able to.
I'll put the link later on in the group, and because that's my YouTube channel, and I have given a live into that so that people can access it. Okay. Yeah. I think then let's say.
I think people need, since we are doing it every once in a month, people need to be reminded very frequently, especially the young people who are busy with their work and all.
No, I have put in this week twice.
Yeah, you had done it. No, you had done your bit, but we'll push the IAN digital group also to send a few more reminders, because they have some kind of a repeated, they have a mechanism of doing it. So we'll ask them also to do, just to, so that more people benefit. Because these are very interesting sessions, very good discussions actually. So I wish more people could have benefited. It is in the YouTube, so please share that information with others.
Yeah.
I think,
Okay, sir.
Do we have the next date so I can put in my diary?
Yeah. Yes,
Or
it
not
is
yet?
there. This
Next day.
next time Sri Chitra is doing, and that will be the first Monday of May. Okay. In fact, I think
We'll come back with more details. First Monday of every month we'll try.
yes, Dr. Gorthi will be announcing the exact paper also. So you can go through it and come. Yeah, first, yeah, it is going to be second.
Sri Chitra is doing, sir?
Yeah, Sri Chitra Technology is doing.
Who is Dr. Sailaja or somebody?
No, her stroke research fellow is, her stroke fellow is presenting.
Okay, so, right. Please send me his details so that I can talk to him.
Yeah, sure. I'll do that, yeah.
All right, sir. Then
Okay,
I'll close. Bye.
Bye.
Good night, sir. Good night, everybody.
Good night.
Have a wonderful.
Thank you, Dr. Rajeshwari and all other.
Yeah, she's really putting a lot of hard work. Full compliments.
Yeah, all the participants.
Thank you, Dr. Rajeshwari. Very kind. Thank you.
Thank you, sir.
Dr. Partha. Bye then.